call a suspected case and what we call a confirmed case. And everything that we're going to be discussing going forward is in the context that the patient at least meets the criteria of a suspected case. So this is the Lusaka situation as of the last update. As you can see, majority of the cases were made up of children less than 5 years of age. Also, among the mortalities, you had a huge number of children, maybe partly because they made up a good number of the admissions, but also because they're quite prone to easily decompensating with any fluid loss. So when we have an outbreak of cholera, like in our case in Lusaka, we tend to refer more to suspected cases than confirmed cases because we assume that everyone in the community has been exposed, and you divert your resources towards managing every case of diarrhea that fits the definition of a suspected case. So based on the case definition, the presenting symptoms you'd expect is watery stools of 3 or more stools. Usually we describe rice water stool, but sometimes there are other colors like yellow or greenish and that sort of thing. They also may have vomiting, abdominal discomfort or pain, weakness, and other symptoms that may be present are fever and abdominal distension, as you may see in extreme cases such as cholera Zika. So when the patient just comes in, so I'm going to ask just the audience to just respond to this question. Where do you think is the best place to assess and manage a child who presents with suspected cholera?
So,
are we running the poll?
Yes, thank you. Thank you so much. So just run the poll so that we see how people are going to respond. So the question is, where is the best place to assess and manage a child with cholera? Is it emergency room, OPD, or B, CTU, C, CTC, and D, Levy or Heroes CTC or Cholera Treatment Center, or none of the above? So where is the best place to assess and manage a child with cholera? It's interesting to see how people are polling. And what is interesting, Dr. Kalima, is all the choices are active, including none of the above. So we have just under 40% going for A, and then B, CTU, C, CTC, then D, Levy or Heroes CTC, and E, none of the above. So it's still very interesting. 2 answers almost at par. So we've got about maybe 20 seconds before we end the poll. We encourage people to actively poll. And don't worry, no one will know that you chose this one. Of course, I can see some people throwing the answers in the chat. Okay. Ending the poll so that we see how we have managed. This is how we have managed. Dr. Kalima, I don't know if you can see. So we have 39% going for A, which is emergency room / OPD, then 13% going for the CTU, and then 33% going for CTC, then 9% going for Levy or Heroes CTC, and then 6% going for none of the above. So interesting responses. Over to you, Dr. Kalima.
Okay. All right. So based on these responses, I can see some of the feelings that I got even as I went to the district last week. The structure at the hospitals will vary. Other places have dedicated areas for seeing children or seeing patients with suspected cholera, whereas others go through the OPD first and then go to a CTU or a CTC. The best place to manage a child is at the point of entry, because some of these children come very dehydrated. You need to assess and decide how you're going to dehydrate the patient as quickly as possible, because time is of the essence. So the emergency room or OPD is usually the first point of entry and would be the best place, even before you send them now to the CTU or CTC. Okay. All right. So when you just receive your patient, you need to assess the severity of symptoms. Okay. You want to know how much stool you have, how frequent it is, how frequent is the vomiting, and is the child able to tolerate feeds, because this will determine whether the child can take ORS or not. You also want to know if the child is able to breastfeed, because sometimes the breastfeeding is the only way the child is able to get nutrition. Is there any weakness, any fever, and do the children have any comorbidities? Remember, these children are still prone to things like malaria, malnutrition. Some may have heart disease, sickle cell, HIV, CKD, and so on. And all of these may make the management of the child more complicated. Of course, we run our routine vitals, which include all of these, and I mean all of these. So coming to my next question, which of these are danger signs? If we can pause this just for a minute.
Okay. So we'll go to question number 2. Okay. And the question reads, which of these are danger signs? Is it A, CRT greater than 3 seconds, B, fast and weak pulse, C, blood sugar less than 3 millimoles per liter, D, temperature of 34.5 degrees, and E, all of the above. So which of these are danger signs? Okay, is it A, CRT of greater than 3 seconds, B, fast and weak pulse, C, blood sugar less than 3.0 millimole per liter, D, temperature of 34.5 degrees, or indeed E, all of the above? We keep on encouraging ourselves to poll. It's good to see just about 60% of the people polling. We have the 40% that are still maybe borderline. We encourage ourselves to poll. So Dr. Kalima, again, of course, we've got one answer that is leading, more than 80%, but we still have other choices being picked as well. Actually, all the choices are being selected in one or another, but one leading for about 86%. Okay, we've got about 10 seconds. We encourage ourselves to poll. It's good to see the number of those that are choosing going up. Please, we encourage ourselves. Okay, so we will end the poll here. So there we go, Dr. Kalima. We've got 3% going for A, 10% going for B, 1% going for C, and then D, 1%, and the largest or biggest number going for E, which is all of the above at 85%. Over to you. Interesting polling.
Okay, all right. So this will soon be understood.
Yeah.
So the initial thing that you want to assess is whether or not your child is in danger. And it's important that we identify the danger signs. So the first thing we encourage people to do when you get a patient with diarrhea is to assess whether or not they have malnutrition. The signs of malnutrition are based on a weight and a height Z score of less than -3 standard deviations. or a MUAC less than 11.5, or they may have bilateral pitting edema of nutritional origin. Okay. So patients with, we're going to discuss this later on, but I just want to remind you, every time that you get a patient, you need to assess for this. You then want to assess if the child has shock. And in this case, all three signs must be present to meet the criteria of shock. So it's a fast and weak pulse, cold peripheries, and a capillary fill time of greater than 3 seconds. The patients may also have altered level of consciousness, such as lethargic or unconscious. In the management of shock, this is for a well-nourished child. We always want to make sure we check for anemia before. If there is any anemia, we transfuse with whole blood because here we're losing volume. We give oxygen, keep warm, and within 5 minutes, we try and insert 2 IV peripheral lines. Ideally, the largest ball that is available for that for the age group. If this can't be achieved, intraosseous access is another option. And by the way, intraosseous access can be achieved quite quickly. So we shouldn't keep trying to look for veins when we can attempt to do an intraosseous access. Check for blood sugar, and any blood sugar less than 3 is regarded as hypoglycemia and needs to be corrected when you're trying to manage for shock, because the volumes of fluids that we give are very high. So if they're hypoglycemic, that sugar will reach 0. So Ringer's lactate is given at 20 mL per kg over 5 to 10 minutes. These are bolus rates, so it's very rapid. You need to evaluate after the first bolus and check if peripheries are warm, is the capillary fill time improving, and how strong are the distal pulses. If out of shock, you then proceed to assess hydration status, because here you're just trying to correct circulatory collapse. So you still assess for hydration status. However, if signs of shock are still present, you have to repeat the bolus, and you are allowed to repeat 2 more times to give a total of 60 mL per kg. Throughout this process, you need to continuously reassess. Shock that persists in the absence of fluid loss should be managed as septic shock. So remember, in cholera, patients may continue to have watery, profuse diarrhea as you are resuscitating. So if they are losing, then you're justified to try and keep rehydrating as hypovolemic. But if they're not losing and they're not responding to your fluids, then you need to consider septic shock. So improvement is improved capillary fill time, good volume pulses, and warm peripheries. You also need to assess for hypoglycemia, because children who are unwell tend to poorly feed and may also be vomiting feeds that they are taking. Children with blood sugar of less than 3 are corrected with 5 mL per kg boluses or 10% dextrose. However, if you are struggling to get IV access, you may give 50 mL of 10% dextrose via an NGT or orally until access is obtained. You have to assess the conscious level, because conscious level may deteriorate with dehydration. Patients who are lethargic or unconscious but no signs of shock with normal blood glucose should be managed for severe dehydration. Patients may present with seizures or have a history of seizures. So in this case, most times seizures may be due to hypoglycemia. So where you can't check the blood sugar, you just correct empirically. However, if you can do that. Other electrolyte imbalances may also include hyponatremia and hypokalemia. You also have to assess for anemia, because anemia dictates what you're going to do if the patient needs to receive fluids. So you need to do this either clinically, or if you can, run an urgent HB. Any patient with HB of less than 7 grams per deciliter needs to have a transfusion. Okay. Patients with severe anemia requiring IV rehydration, so that is plan C, should be given a maintenance fluid while awaiting transfusion, because those volumes for plan C may actually lower that HB even further and cause even more issues. Plan B and Plan A patients may be given ORS cautiously but need transfusion if severely pale. For patients with hypothermia, these children are really prone to hypothermia. In my visit to the CTC last week, I noticed that with the setup there, sometimes it's very easy for children to become hypothermic. So it's really important that we keep these children warm. Sometimes blankets need to be changed more frequently because sometimes they vomit and so on. So a temperature of 35.5 or less than 35.5 is regarded as hypothermia, and these need extra blankets and active warming. However, we need to remember that this may also be due to shock or maybe due to hypoglycemia. So this also need to be corrected. So on to the main business, which is assessing for dehydration. So that we can put up the third poll question. Maybe this one we can run for 30 seconds because we are short of time.
Thank you so much indeed. We're running out of time, given that we've got two presentations. So really just 30 seconds, and then for question number 4 and 5, we may not run them, but we'll just probably want you to go through. So just 30 seconds from the time that we launch. Which of these are the signs of severe dehydration? Is it sunken eyes, A, or B, skin pinch goes back quickly, C, lethargic or unconscious, D, poor takes fluids orally, okay, or E, A, C, and D. And A, C, and D are sunken eyes, skin pinch goes back quickly, or lethargic or unconscious. Which of these are the signs of severe dehydration? Please keep polling. We've got like 10 seconds now. Okay. We'll end the poll here. It's good to see one answer leading the pack. Over to you, Dr. Kalima. This is how people have polled, with E getting 83% and the least being B, skin pinch goes back quickly at 1%. Over to you.
Okay, thank you very much. So E is the correct response. Sunken eyes, lethargy, or unconscious, poor oral intake are signs of severe dehydration. So with patients with severe dehydration, you expect at least 2 of the following signs. Like was mentioned, lethargy, lethargic or unconscious, absent tears, very sunken eyes, or dry eyes, absent or a weak pulse. Not able to drink or drinks poorly, and skin pinch goes back very slowly. And these often have dry mucous membranes. These are managed with IV fluids, that's Ringer's lactate. All of this is after you've done or corrected all the danger signs. So you give 30 mL per kg in 60 minutes for children less than 1, and 30 mL per kg for those over 30 minutes for those greater than 1. You reassess after each bolus. If the patient still has a weak pulse, you need to repeat the bolus. And then you go on to give the 70 mL per kg boluses as shown in the slides. Once you reassess the patient, if the patient still has severe dehydration, you need to repeat the IV fluids. If they have some dehydration, you then move on to plan B. But if they have no dehydration, you move to plan A. These are the patients that you want to give antibiotics to. The only patients you're going to give IV antibiotics to. Oral antibiotics to. So the choice of drug is doxycycline for this outbreak. And then alternatives are azithromycin and Cipro. The patients with some dehydration will be irritable, will have sunken eyes, will have a rapid pulse, will be thirsty or drink eagerly, will still have a skin pinch that goes back slowly, but not very slowly. And they may also have dry mucous membranes. These are rehydrated with ORS at 75 mL per kg, and these have to be reassessed in the same manner. If they are deteriorating, which may happen in cholera because of the profuse losses, you then move on to plan C. If they have some dehydration, you repeat ORS, and if they have no dehydration, you move on to plan A. Breastfeeding continues throughout rehydration, so these often are able to take orally, but if not, you can use the NGT. For no dehydration, they have no signs of dehydration in short, and these are managed with plan A. So for every loose stool, you're giving them 50 mL per kg, 50 mL per loose stool for less than 2 years and 100 mL per loose stool for those older. And these need to be fed because they may become malnourished. So this is an example of the reviewing and monitoring charts that we developed for this outbreak. This just summarizes everything that you'll be doing at each subsequent review. We were trying to move away from using files and that sort of thing and just having one chart where you can track everything that you're doing for your patient at each review, and you focus on the main issues. This is mainly for those patients who are just being managed for diarrhea, which is suspected to be cholera. Here's an example of one of the patients we viewed at Kanyama last week, just showing you the progress and how we use the science to decide how they're doing. For the SAM patient, we mentioned the 3 criteria earlier. Remember that these patients may also have dermatosis, so you need to look out for that. These patients are important to assess, but they're also difficult to assess because the signs of dehydration that we often rely on are not always reliable. Things like skin pinch, sunken eyes are present even in patients with malnutrition, and any excess fluid given to these children may also cause overhydration. In these patients, the rehydration is done using ORS if they are being managed as suspected cholera, not Resomol. The only indication for IV therapy is in patients with circulatory collapse. Okay. So we said we skip this one,
Yes.
but people can have a look at this later. Yeah.
Yes. Yes.
So this is just a reminder of what we did before, but it just emphasizes the importance of correcting these. Hypoglycemia is a very common feature in patients with malnutrition. So this needs to be corrected as quickly as possible. And for these patients, we don't hesitate to give orally if we can't get IV access. If the child is given IV fluids for shock, there's no need to follow the first boluses of glucose with more glucose because they will be receiving glucose within their IV fluids. When you're treating for hypoglycemia, as soon as the child is able to take orally, you need to start giving them F75 as well to correct hypoglycemia. You need to keep these children warm because hypothermia tends to precipitate hypoglycemia. For hypothermia, once again, you need to actively warm these patients and ensure that they are not hypoglycemic, and that may be the cause of the hypothermia. You may also want to give antibiotics to these children because sepsis may also cause hypothermia. Temperature needs to be monitored every 30 minutes. You also assess for anemia in these patients, but the threshold for transfusion for some patients is much lower at 4 grams per deciliter. And these are transfused more cautiously with 7 ml per kg packed cells instead of whole blood. In terms of dehydration, so we'll skip that. So the patients with dehydration and circulatory collapse, essentially these patients are in shock. They have similar features, but once again, these are not reliable. So not being able to drink or drinks poorly may just be a feature of because the patient is lethargic or malnourished. Sunken eyes are often seen, once again, among malnourished children with wasting, but not so with those with edema. The skin pinch may go back slowly for the same reason. They may be lethargic or unconscious, which may be due to hypoglycemia, but also may be due to dehydration. So the features of circulatory collapse are much more reliable, such as a fast, weak pulse, cool peripheries, and prolonged capillary fill time. With these patients identified to have these signs, you need to give Ringer's lactate with 5% dextrose or Strengtharos with 5% dextrose at 15 ml per kg over an hour. So this is not bolus rate, but over an hour. And you need to monitor the pulse rate and respiratory rate on the progress chart every 5 to 10 minutes. After an hour, you need to assess for signs of fluid overload. You need to assess if there's no improvement, in which case you want to, without no improvement without any loss, you may suspect septic shock. But if a child is improving, you can repeat the same amount of fluid and then start to alternate between ORS and F75. So fluid overload is thought to be present if there's increasing edema, if there's increase in respiratory rate by 5 or heart rate by 25 with static or increasing weight. If there's engorged neck veins, in all these cases, you need to stop IV fluids. But however, cholera patients tend to have profuse diarrhea. So you may still have increasing respiratory rate and heart rate simply because the child is becoming more dehydrated. So you need to check that there are no losses. So you stop IV fluids and consider diuresis if patient has respiratory distress with crepitations. For those with some dehydration, we assume that all children that have the case definition of cholera, which is the profuse diarrhea of more than 3 episodes, have at least 5% dehydration, and these are rehydrated using ORS. Here it's more judicious. We're going to give 5 ml per kg every 30 minutes for 2 hours with a total of 4 doses. And we monitor the pulse rate and respiratory rate every 30 minutes. After 2 hours, we also check for signs of fluid overload, which have been explained. And if the child is worsening, and has circulatory collapse, we need to then go on to manage with IV fluids. But if the child is improving, we then give 5 to 10 mL per kg of ORS alternating with CF75. If that is no improvement, and this can be done for up to 10 hours, and those that are improving can then go on to ORS of 50 mL per kg per loose-2 or less than 2, and those order at 100 mL per loose-2. The one with no dehydration has no more signs, but this child still needs to be fed and still needs to receive ORS per loose-2. The other steps in managing some patients include feeding. It's very important that as soon as possible, these children start feeding. And once they start to improve and they're able to tolerate, we start to assess for appetite and also see if we can transition to F100. These patients also need to be weighed daily. Or some patients require antibiotics. So these ones, regardless of whether they have no dehydration, some dehydration, as long as they meet the case definition, they need to be given the doxycycline start dose. We also need to give them the routine antibiotics that are prescribed for some patients and any other medications such as ART and so on. However, these patients do not receive zinc supplements because this is contained in the feeds. This is an example of the SAM monitoring tool that was developed for this outbreak. It's similar to the previous one, but here it gives you a guide and an emphasis towards the monitoring in the SAM patient. Other steps for the patient include investigations. So we encourage, depending on where you are, because I understand people are coming from around the country. In Lusaka, we are in outbreak stage. So in our outbreak, cholera testing is not routine. We do test on a daily basis for surveillance sake. We do 3 to 5 patients are guided by the SOP, and then sometimes we also test for E. coli and Salmonella. All some patients have to have samples collected because in some patients there may be other organisms that may also cause diarrhea of the similar type. One of the tests that has to be done is a modified ZN stain, particularly among those who have HIV, because it may also give you profuse diarrhea when you have cryptosporidiosis. Other tests to do is full blood count. As we said, anemia is an important issue. Malaria can cause anemia, and we're in different settings, so it's important to test for those. HIV testing is also important because, once again, this may be the first presentation. Electrolytes are not always routine, but they are important to monitor in those who are not improving or have things like seizures and so on. So it's important to check those. And then blood gas monitoring, once again, for those who have complications. The discharge criteria is indicated here. People can go through it at their own time, but I just want to mention that some patients need to be transferred to the malnutrition ward after discharge from the CTC, okay? Because they need to continue their management at the end.
Yes. Okay, thank you. Thank you so much, Dr. Kalima. And it's good to see a good number of people joining, a total of 842 as we speak. So we'll just allow 2 minutes. Any question within 2 minutes. Thereafter, we'll go to our next presentation, which will be done by our specialist, Dr. Mwemba, on electrolyte imbalance and acid base in cholera. So any reaction? Okay. So Dr. Kalima, any take-home point or points in these few minutes?
Okay, I see a few hands. I don't know if how many hands are we allowing?
Okay, okay, we'll just, I hope they are just comments. So we'll start with Mwaka Siakwenda. Yes, Mwaka, please unmute yourself.
Good afternoon. Am I audible?
Yes, you are.
Thank you so much for the presentation. It was well informative. I just wanted to get some clarity for patients that we're managing with SAM. Are we giving them ORS or we are supposed to give them Resomal?
Okay, thank you. Next, Chuye. I hope Dr. Kalima, you've taken notes. Chuye, Patrick.
Thank you very much, Chair. I just wanted to have a clarity on use of ciprofloxacin and doxycycline, because previously what is known to be the first drug of choice are the tetracyclines, which particularly doxycycline. In the other presentation, we are talking of ciprofloxacin as the drug of choice. Thank you. Just a clarity on that one.
Thank you. And maybe the last one for now, Makai, your question.
Thank you so much, Chair. I think my question also is similar to the one that has just been asked. I wanted to know the drug susceptibility with the strain that we have now of cholera, so that we can be well guided on which drugs to use as our first choice.
Thank you so much. I know we have Anel who has joined. He had put up his hand in terms of susceptibility, sensitivity, and I think he can comment on that. So we'll right away probably allow Dr. Kalima to just react to those questions, and then Anel will wrap it up.
Okay, hello?
Yes, go ahead, please.
Okay, so for the first question, the rehydration fluid of choice is ORS. Okay, so this is the one instance where you do not use Resomol for rehydrating some patients. And then concerning the antibiotic susceptibility, so this is as of 2 weeks ago when we had this discussion to say the antibiogram that was done for our current outbreak shows that doxycycline is still top, and we still have susceptibility to azithro and ciprofloxacin. Doxycycline is quite suitable for various reasons. I know Anna will probably elaborate on this. And also, because it's a short course, we have no major concerns for side effects. And studies have shown that short courses of doxycycline do not give the reported side effects that are seen in children. Okay.
Would you want to speak to that wonderful slide that you shared yesterday, where we had five drugs: tetracycline, ciprofloxacin, chloramphenicol, cotrimoxazole, and ampicillin, and the sensitivity? Anel, are you still joined? Okay, so just run through. So we had tetracycline showing 7 out of course, 71, showing resistance, and then the sensitivity was 61. Cipro sensitivity 65 against 1 resistance, and then chloramphenicol 40 resistance, and then for cotrimoxazole 67 resistance, and then ampicillin 70 resistance. So of course, leaving us with Cipro, and then of course, Doxy as well. So I hope that adds to the answer that Dr. Kalima has given. These slides, in case you did not receive yesterday, can be shared with you, including what has just been presented. Thank you so much. So at this point in time, we'll let go Dr. Kalima. Thank you so much. And in case of any questions, please feel free to get in touch with our presenter. We'll now go into our next presentation, and that is Dr. Mwemba, and he will run us through electrolyte imbalance and acid base in cholera.
Okay, so sorry, Chair, thank you very much for that. I just want to excuse myself because I have to go and attend to something. So if people have questions, like has been mentioned, they can get in touch.
No problem. I will just ask that probably you drop your contacts in the chat box, if that is okay.
I'll share my email.
Okay. Sorry, just trying to share. Okay, thank you so much. So Dr. Mwemba, over to you. Just.
Okay. So good afternoon. I think I don't have to introduce myself. Davis has already introduced me. So yeah, I'll look at the electron imbalance and acid base in cholera. I'm sorry if there'll be too much detail or less detail. I was just informed last evening that I should prepare this slide. So they're too simple, forgive me. And again, if they're a bit complex, kindly forgive me. So I think that I'll just introduce a bit of physiology, GI fluid and electrolyte physiology. And what you see in that is that that's a bag. So that's how it looks like. So
no, please go ahead. Just run.
I think that so I'm not going to ask people to answer the questions. Yeah. I just want them to stimulate you. So the first one is, what type of diarrhea does cholera cause? And so you have two options there, either secretory or osmotic, and then you can answer on your own. The second poor question goes, the normal physiology uptake of water and electrolytes in the GIT involves A, absorption and secretion, B, absorption only, C, secretion only, and D, does not involve absorption and secretions. Again, you can answer and then we'll look at them at the end of the presentation. I hope you can see well here. I'm just trying to show you how water and electrolytes are absorbed in the GI. And there are basically four pumps that I just want you to, not to memorize, but to know that they exist. And the first one, as you can see, takes in either glucose in and sodium in, using those special pumps, or it can take in sodium in or amino acid in. And I should mention that this pump is very important because this is the pump that your ORS is based on. So, and you can see that it has a major contribution to absorption of water and electrolytes. The second one is what we call the sodium hydrogen exchanger. And as you can see, hydrogen, which is produced in the cell as an acid, is pushed out and sodium goes in. The third one still involves the sodium hydrogen exchanger. But on top of that, you see that chloride is taken in and bicarbonate is taken out. So when you take in a negative electrolyte, another negative electrolyte that has to come out. And in this case, it's an exchange of chloride and bicarbonate. I think that when I come to a bit of pathophysiology of cholera, I have to mention this pump because it's very important. And the cholera toxin does affect this pump, and that's how chloride comes in. And then the last one is where just sodium can go in on its own. As you can see that these pumps, you find them also in the kidney. And so they are almost like a replica of what you find in the kidney. So when this happens, it means there's a lot of sodium that goes into the cell. And because sodium goes into the cell, at the basolateral end of the cell, there's a lot of, there's a normal pump also which pushes out that sodium into the interstitial. And because of the sodium that goes this side, is there a pointer? Okay, so there's no pointer. But once that sodium is pushed this side, automatically water will start to follow that path. And other electrolytes, potassium and magnesium and calcium, they also follow that path. And that's how water is reabsorbed. The next cell is just the secretory cell. So what we were discussing initially was, so apart from absorption, there's also secretion. And this is very important just to make sure that the lumen of the intestines is always kept a bit moist. And this happens in other organs like the lung, the respiratory tract itself. And so whatever I'm describing here does happen also in other lining of the body. And what is important here is that you can see again that on the inner side, the blood side, there are other pumps that do pump sodium into the cell, and I'm not going to go and try to mention them. But the most important one is the chloride pump that is mediated by a special receptor we call the cystic fibrosis transmembrane receptor, which is very important in cholera. And I think that maybe someone, as you were discussing cholera, someone should have mentioned this. So this particular receptor that's what cholera actually binds to or stimulates, and then it becomes very active and starts releasing that chloride outside. Now, when that chloride is outside, it creates a negative charge in the lumen, and therefore sodium will follow it into that lumen. And once sodium follows it into that lumen, then water also will be gets to be secreted. So as you can see, there are two processes here that happen. There's a process of absorption, and there's again the process of secretion. And so this is just a summary of what actually happens. That when you eat something, we usually take about 2 liters of water, and then in the saliva there's another 1,500, and then in the stomach another 1,500. In the liver contributes another 1 liter. Pancreas another 1 liter. So by the time you are entering the intestines, another 2 liters is secreted by the intestine. So you make, like, in the lumen, about 9,000 liters that is secreted. Of that 9,700, almost 8,000 is reabsorbed. And so at the end of the whole 9,000 that is produced, you end up just having 150 that is. So you can see that both the absorptive is very powerful, such that whatever you secrete has to be taken back. So that's the normal physiology. So we go to question number 3. The fluid lost in cholera is mostly A, hypotonic, B, hypertonic, and C, isotonic. And so you can answer again this question, and then we'll be able to answer it at the end of the presentation. Question 4, normal saline is the most indicated when fluid loss is more from vomiting than diarrhea. So if a patient comes with vomiting, and probably no diarrhea or more diarrhea, what is the appropriate fluid? Is it normal saline or something else? I think that's what this question is trying to answer. So I'll go now to a bit of pH again and just take you first what pH looks like. So the normal pH, as you know, is between 7.35 to 7.45. Anything below 7.35, we call it acidosis, and anything above 7.45, we call it alkalosis. And in the body, that temperature, that pH has to be maintained. And there are threats to this pH. And I'm just trying to show you what are these threats to pH. So one of the first threats to pH is your production of carbon dioxide. So as the cells are dividing and they're producing this carbon dioxide, it can threaten your pH. And so you can have high pH and that can rise. And so we call that as volatile acids. The second one is the fixed non-volatile acids. And the two that are common is sulfuric acid, which is produced when you are oxidizing your sulfuric containing amino acids like methionine and cysteine. And then phosphoric acid, which comes up because of metabolism of phospholipids, nucleic acids, when you eat meat and all those things, so they will produce that acid. And the third one is your organic acids. I think some of you who've done DKA, you remember those acids, lactic acids, acetoacetate and butyric acid. And usually these are formed because of carbohydrates metabolism and fat metabolism. There are defenses against this pH. So if the pH goes up, you bring in what we call defenses. And the 3 main defenses are acid-base buffer. In this case, the most important one is the bicarbonate, and we'll be discussing bicarbonate. And this occurs within seconds. So whenever the pH hydrogen increases, within seconds there will be a defense that comes in, and that's the bicarbonate system. If that fails, the respiratory system will come within minutes. And if that fails within hours, the kidney will come to the defense. Again, just to illustrate that the pH is between 7.35 to 7.45. And those are the normal values for your pH again, 7.35, 7.45. And the partial pressure of carbon dioxide is 35 to 45. And that's important to remember because we use that for our calculation of acid. And then the bicarbonate is 22 to 25. So as you can see that actually carbon dioxide is an acid and bicarbonate is the base. So we use the two as either to determine whether you are acidic or you are alkalinic. And these are the 4 different types of acid base. So you have metabolic acidosis, and I always say that whenever you see an acid-base script, just look at what has happened. If everything is pointing downwards, just know you're dealing with a metabolic acidosis. If everything is pointing upwards, it means you're dealing with metabolic alkalosis. If one is pointing down, which is the pH is down, it shows you acidosis. But if the other 2 parameters are pointing up, it means you have respiratory acidosis. And the opposite for respiratory alkalosis. If the pH is up, it's alkalosis. And so you expect that if it's respiratory, the other 2 will be pointing down. So this is just a simple diagram that you can use sometimes when you have an ABG to come up with a quick workout and find out what type of pH what type of a metabolic disorder that, acid-base disorder that you could have. I mentioned that we have, in cholera toxin, it enhances the secretion. So we discussed the absorption and we discussed secretion. So what it does actually is enhance secretion of the normal physiological process. And what I'm showing here is the toxin itself. I don't want you to memorize it, but what this toxin does that it increases your CAMP, and the CAMP, you can see that it stimulates the cystic fibrosis transmembrane receptor that is important in the chloride secretion. And once that is stimulated, it means that you'll be pushing a lot of chloride here. And once you push a lot of chloride here, you see what happens. So here I'm still showing the same two processes, the absorption and the secretion. And obviously here, instead of showing all the 4 pumps, I'm just showing one of the pumps that is very important and is affected by the cholera toxin. And I'm showing you the secretory cell that is affected with cholera toxin. And this CFTR is what is affected. So it tends to start functioning it is stimulated, and therefore it releases a lot of chloride into the lumen. And once this chloride is released into the lumen, the absorptive cell picks it that there's too much chloride into the cell. And because of that, it starts to reabsorb part of this chloride. And in doing so, it pushes out bicarbonate. And so bicarbonate is pushed out because of that. And because of this, there is high luminal chloride, which stimulates, like I've said, this pump, and therefore it secretes a lot of bicarbonate. And the increase in luminal bicarbonate and chloride that is already coming here, it means that this area is very negative. And what will happen is that on the sides of the cell, there's a paracellular movement of sodium, which comes into this lumen. And once sodium moves into this lumen, it then pulls water into here. And so you have high volumes of diarrhea that comes in, and so you start losing a lot of water. And so this is the basic mechanism how cholera does cause massive diarrhea. Now, just apart from bicarbonate, chloride, sodium, and potassium, if the diarrhea is very heavy, calcium and magnesium can also be lost. And because it follows this water that is in here, it means that the at the end of it all, the stools that you are commonly going to get will be isotonic. So commonly to be an isotonic fluid. And therefore, that's why you see that we give ORIS to make that fluid isotonic. And we also give, when it's severe enough, we give Ringer's lactate, which is also isotonic. If you're going to give normal saline is hypertonic. And so you're going to affect the physiological balance of that. And so commonly, that's why the reasoning for Ringer's lactate and the reasoning for ORIs. So what are the acid-base disorders and electrolyte disorders in cholera? I think partly I've explained in that slide that I've just left, but usually it's secretory, like I've said, and therefore most times you will have an isotonic loss, and these losses can go up to 1 liter per hour, or in children up to 20 to 30 mils per kg per hour. And therefore fluid replacement should be isotonic. And the isotonic is ORIS or Ringer's or any other isotonic fluid that you will have. Electrolyte imbalance. The electrolyte imbalance or acid disorder occur when the kidney fails to adjust excretion. So you need to have high volumes to lose before actually you have an imbalance in the electrolytes, and you have acid-base disorders. So it's those severe sick patients that will have abnormal electrolyte. And that's why you see that those mild and moderate, you just give them the isotonic fluid and they will recover. Hyponatremia can happen, and the risk people are children, or if you're going to resuscitate with IV dextrose for resuscitation, or if the child is being given plain drinking water, because and therefore that is water is going to be reabsorbed, and therefore it will dilute what is in blood, and therefore it causes hyponatremia. And then comorbidities like heart failure, malnutrition, nephrotic syndrome, and chronic liver disease that usually tend to have what we call inappropriate secretion of ADH. So if you're producing too much ADH, it can dilute your serum sodium, and that can cause hyponatremia. So there should be a risk. Hyponatremia, same as well, common in children, or an individual has used too much normal saline to resuscitate, or you're giving the patient sweet drinks or juices that are going to cause an osmotic diarrhea on top of the cholera. That is going to cause hyponatremia. Hypokalemia, again, common in children, and it occurs in severe dehydration. And commonly, this happens because of the volumes that you're losing. As you know, potassium tends to follow where sodium is because of the volumes. So you lose the sodium between that. But at the same time, there's also the compensation by the renin-angiotensin mechanism that is going to increase your renal sodium reabsorption. But once you increase the renal sodium reabsorption, it means you have to sacrifice your potassium. And so potassium secretion will be increased in the distal tube, and this can lead to hypokalemia. And in severe forms, therefore, there is a benefit that you have to check the potassium. And when you check the potassium and it's low, that potassium has to be replaced. Hypokalemia, as you are aware, can be associated with other electrolytes loss, calcium, magnesium, and phosphorus. And therefore, it is also important to check this. If a patient is vomiting and they are losing fluids because of vomiting predominantly, just to remind you that the gastric or the stomach contains about 160 millimoles of chloride, and that chloride is usually balanced by positives, which are potassium, sodium, and hydrogen. Under normal conditions, your sodium is the primary cation. But when stimulated, your hydrogen goes up in the stomach, and it can go up to 100 millimoles per liter. The potassium remains the same whether the gastric mucosa is stimulated or not stimulated. So it remains around 10 millimoles per liter. So when you vomit, you induce a loss of this chloride, and there can also be a loss of hydrogen. And therefore, this loss of hydrogen and chloride, the chloride will be replaced by the bicarbonate. And once the bicarbonate replaces chloride, it means that then your pH will go up. And once your pH goes up, it means that you have metabolic alkalosis. So severe vomiting causes metabolic alkalosis. And in that case, to treat that, it's better you treat it with the isotonic saline. So this is in a so isotonic saline is only indicated most times when a patient is vomiting too much, and that vomiting is more than the diarrhea. If the patient has low potassium at the same time, you might want to replace the potassium with potassium chloride. Okay. There are two forms of metabolic acidosis, I think, as you are aware. Either you can have metabolic acidosis with a normal anionic gap, or metabolic acidosis with high anionic gap. And what do we mean by that? So you pick the ions that are positive, and most times we do is sodium and potassium. And then you pick the ions that are negative, and most times it's chloride and bicarbonate. And so there should be a normal gap between the bicarbonate and when you combine the bicarbonate plus the chloride. And you subtract that from sodium and potassium. And this anionic gap, what it means that there are other things that you can't measure. And these other things that you can't measure are the ones that are listed here. We can't measure these. But if we were to measure these, it means that there will be no gap. And that's why we call it normal anionic gap. So that normal anionic gap is usually around 10. And I'll give you the formula later on how to calculate it. So each time that we measure these electrolytes, we want to know whether this is normal or it's not normal. And that normal just means that there are electrolytes that you can't measure, but they are accounted for. So in other words, the body should be in a neutral position at any given time. But because we can't measure some of the negatives, there will be that gap. Now, metabolic acidosis can either deplete can either make you gain chloride. So when you lose bicarbonate, you gain chloride. And so once you gain chloride, it means that it's covering for that gap, and therefore you will have a normal anionic gap. But if you're not gaining in chloride, it means that the chloride will remain normochromic. And therefore, when you measure that gap will be high. And so we call it high anionic gap. So metabolic acidosis can either be high or normal anionic gap metabolic acidosis. And for normal anionic gap metabolic acidosis, there are only two causes, either diarrhea or renal. And so in cholera, most times you will have a normal anionic gap metabolic acidosis, because the chloride, even if you lose it, you don't lose it as much as you lose the bicarbonate. So it tends to balance up, and you have a normal metabolic anionic gap. This is just how you calculate, and I'll leave these slides. I'm not going to, but just like I said earlier on, you add sodium plus potassium, and then you subtract chloride minus whatever, and it gives you something between 4 plus minus 4. If you haven't added the potassium, it means that that figure will probably be less, and so it will be 12 plus minus 4. So that's a normal gap. So question number 5, and which is the last question, cholera is unlikely to cause the following acid-base disorders. 1, high anionic gap metabolic acidosis. 2, normal anionic gap metabolic acidosis. And 3, respiratory acidosis. And number 4, metabolic acidosis. And 5, respiratory acidosis. So here I'm just trying to look at which of these disorders is cholera unlikely to cause. So this table just summarizes all the metabolic classification of acid-base disorders in cholera. And as some of them, obviously, I've already discussed them, and this should be our last slide. So cholera can cause a normal anionic gap metabolic acidosis, and I think that I have already explained this, and it's because of the diarrhea. And the diarrhea is because you're losing more chloride and bicarbonate. Okay. The second one is that it can also cause high anionic gap metabolic acidosis. And the reason here is that because sometimes you have a shutdown of blood flow, you will have type A lactic acidosis due to poor perfusion. And the lactate will increase the gap, and therefore you have a high anionic gap metabolic acidosis. Cholera can also cause metabolic alkalosis. So if you are only vomiting and the vomiting is more predominant than the diarrhea, it means that you are losing more chloride and you're losing more hydrogen. And therefore, it will shift that to metabolic alkalosis. Cholera can also cause respiratory acidosis. And this usually happens because you will have muscle weakness, either because of calcium loss or because of potassium loss. So your diaphragm won't be moving as much as it can. So it will be retaining your carbon dioxide. And once it retains your carbon dioxide, it means then you will have respiratory acidosis. Respiratory alkalosis is very unlikely. It can happen when someone is hyperventilating, but very unlikely. Mixed disorders, probably they are also common. So you can imagine that you have hypokalemia and you've got very severe diarrhea, so you have metabolic acidosis there. At the same time, you have hypokalemia. Hypokalemia will cause muscle weakness. Once it causes muscle weakness, it means you can have a combination with respiratory acidosis. So these four can come in different ways. And so sometimes when you're analyzing the ABG, you need to take into account this. We are not going to go into the compositions and how you calculate that, because I think that's just a basic lecture that we're giving. Okay, so we have come to the end, and I'm just trying to go back to the poll questions and then give you the answers to those poll questions. So what type of diarrhea does cholera cause? So it's secretory. I hope you got it. The normal physiology uptake of water and electrolytes in the GI involves both absorption and secretion. The fluid loss in cholera is mostly isotonic. Normal saline is the most indicated when fluid loss is more from vomiting than diarrhea. So you have a patient who's vomiting completely, whether cholera or not cholera, just know that probably normal saline might be the right choice for you to give. Otherwise, the best fluid for adults is Ringer's lactate. Obviously, children, they'll tell you that probably Darrow's might be the best for them because they tend to lose more potassium. Cholera is unlikely to cause the following acid base, and that's respiratory alkalosis. Otherwise, it can cause the other acid-base disorders. To conclude, so in summary, cholera commonly causes isotonic diarrhea. Hyponatremias are common in children, especially when they ingest fluids that either have high or low tonicity to plasma. So depending on what else extra you are taking, that can cause imbalance in sodium. Hypokalemia is common and should be sought for those who are severely dehydrated. And acid-base disorders can occur in severely dehydrated patients. And then I should end here and thank all of you, unless there are questions.
Okay, thank you so much, Dr. Mwemba. Your session has reminded me of my third year when we were talking of ion trapping,
yes,
the drug absorption, yes, in which area are drugs absorbed, acidic drugs, yes, or basic drugs, and issues of toxicity, exactly, and if you want to flush out through the kidneys a given drug. Very, very interesting indeed. So I'll allow for reactions from the network. We can see we have CK and then Kabaso. Those are the ones that have put up their hands. So just we'll start with CK. CK, please go ahead and be brief in your question. CK.
Okay. Yes. Are you getting me?
Yes. Please go ahead.
My question is on the situation where now we have this cholera patient who has a comorbidity, let's say is hypertensive as well, or has got CCF, and where you are restricted in terms of giving the fluid because they have this effect. What do you do in those kind of situations now where this patient as well who has cholera also has hypertension or CCF where fluids are restricted?
Dr. Mwemba?
So thank you so much. So if the patient obviously has just hypertension and they have also cholera, they'll be dehydrated. And so the most important thing is to hydrate. The BP might go up, but you'll have a choice of medication that you can give just to control the BP. And most times we tend to say the safest drug that you can probably give is the calcium channel blockers. Even when a patient has CCF, we do give fluids when you have CCF. Obviously, the monitoring there might be a bit whatever, and that patient might have to be referred because the resuscitation there might be a bit different from an ordinary person, but they'll still need fluids. Only that the way we give those fluids might be different from an ordinary patient. So you have to balance, and probably if you need a central line, it would be nice that you put a central line so that you can monitor actually the pressures in the right atrium, and that can guide you how much fluid you need to give.
And at what rate?
And at what rate.
Thank you so much. I hope that is clear. We have another hand up. Dr. Mwemba, please go ahead.
Thank you so much for the presentation. Thank you, Dr. Mwemba, such a soft teacher. I have a question on, or basically, I just want a comment on vomiting and emetics. Just a comment on that. Thank you.
Yeah, so whenever someone is vomiting, obviously, we don't want them to vomit. But obviously, you have to choose your antiemetics very well, because the challenge is sometimes those antiemetics might worsen, as you know, that some antiemetics might, antihistamines especially, might worsen the cholera or whatever. But once someone already has cholera, I do not think that there's any fear that you do not give the antiemetic because they might cause more damage to the esophagus. So I'd still give the antiemetic.
Okay. Kabaso, I hope that is okay. We've got Dr. Clive Banda, whose hand is up as well. So we'll just allow 2 more questions after this, if there are any. Dr. Banda?
Yeah, thank you so much, Chair, and thank you so much, Dr. Mwemba. That was a brilliant presentation, very informative indeed. We really appreciate it. Yeah, so mine is more of application of the information that we have. I think for other provinces, the situation might not be as it is in Lusaka, where we have, access to electrolytes and also acid-base, investigations and so forth. So the fact that we're having these patients in these peripheries, and most of them are actually presenting with these complications. Case in hand is a patient we had in Macha who had severe hypokalemia, which was only, suspected from an ECG. Is there a way we can come up with simple, clinical predictors, some sort to guide management of these severely ill patients in areas where we do not have access to electrolytes, access to acid base, and others actually may not even have ECGs? I submit.
I think it's a very tough question. But obviously, if a patient is passing urine, and they are passing enough urine and they have massive diarrhea, the chances that they have hypokalemia is high, and they have muscle weakness or they have paralysis, and they are weak in walking. It means that maybe most likely you have hypokalemia. And therefore, in that, whatever is that, I might start just to replace. I might use Davos if I really suspect that we do in children, and so there will be no harm to start using Davos. The Ringer's lactate does contain enough potassium, but it might not contain enough. And so in those that I really suspect and they show clinical signs that they might have hypokalemia, I might add a vial of bicarbonate to each of the liter that I'm giving. Not bicarbonate, but potassium chloride to each of the liter that I'm giving, just to make sure that they have enough potassium.
Okay, thank you so much. Our last question, I know time is up.
And just to mention that the ones that you need to look for it are those that are severe dehydration. So they are in shock and they are passing urine. Maybe those you can prophylactically give potassium chloride.
Thank you, Dr. Mwemba. So our last question, I know time is up. We'll just ask, just written iPhone. We'll send a request to unmute. Just introduce yourself and then please go ahead and ask the question.
Hello, good afternoon. My name is Dr. Mapani. Thank you very much, Dr. Mwemba, for that comprehensive presentation on the management of cholera. I just wanted to make a comment on the clinical care for children and the use of antiemetics. So in children, we usually do not use antiemetics because we believe that the use of antiemetics, which most of them have sedative effects, may end up sedating the child and compromise on the clinical care. And also because of some of the side effects, like the extrapyramidal effects and so forth. So for children, our mainstay, even if the child is vomiting, our mainstay will be to replace the fluids and electrolytes that the child is losing. And in due course, we believe that that will take care or reduce the vomiting. So I just wanted to make that comment. Thank you very much.
So I think, thank you so much, obviously, Dr. Mapane, and I think that that's very important. But as long as that vomiting is very severe enough, I'm just talking as just general, but obviously I think that there should be guidelines to inform people how they should manage children and or the general population, everyone else. But obviously, if you came to me, I'll ask you that the more they vomit, the more likely that the imbalance might get worse. And if the imbalance gets worse, it means that they might actually go into a coma, because what might affect everything else is that they will have alkalosis, and later on they'll go into a coma. And sodium imbalance will take place, and both hyponatremia and hypernatremia can cause coma. So I'm just commenting that, but I think that in the general advice, I think it's important on the general, population, that in the general population, those who can't monitor those kids, maybe they can restrict how much emetics they have to give. And so I do agree. I guess it applies also to the adults, because even the adults, they'll still react to their emetics. But obviously, if you came to me, I'll act in a different way, because obviously I'm a specialist. I think maybe we can make that difference.
All right. Thank you so much. I'm sure every one of us will attest to this fact that it's been an interesting 2 sessions that we have had. We had Dr. Kalima talking about management of pediatrics, and then Dr. Mwemba coming in with his specialty as well in relation to the imbalances and the acid base and cholera. Wonderful time indeed, and great questions that came through, and we hope that we've gotten the feedback that we desired. These slides will be shared with everyone, so please feel free to still refer to the literature that has been shared. And then just to also alert us, tomorrow, same time, we have another topic, and that will be IPC in CTCs, or of course, infection prevention and control in cholera treatment centers, same time. So we hope to see you again tomorrow at the same time. So from me and the team here, Dr. Mwemba, and I also have Dr. Ziambo, we thank you and have a good day, and please make sure we keep safe. Thank you.
Thank you.
Thank you.